That's a really interesting point. And I also wanted to add, a lot of times people ask me, oh, well, should I do MSE or should I go right into double jaw surgery? And a big thing about double jaw surgery is that it gives you that counterclockwise rotation. It addresses that facial length issue. But and this never occurred to me, but this is another reason why patients should start with MSE before getting into double jaw surgery, because some of that counterclockwise rotation can be accomplished with the MSE.
Now, that's a very interesting thing you mentioned. I have oral surgeon, Dr. Stephen Vaughan, which I want to bring him to an interview with you in the near future. He's my go-to surgeon on the airway. In our common double jaw surgery patient, he always recommend MSE with it, because according to him, just by simply doing the jaw split doesn't really give you an increase in airway as much as the MSE will provide. Okay, so MSE actually provide the expansion because we didn't really cut the jaw loose like a two dentures. Okay, now the double jaw surgery, you actually cut the whole upper jaw loose. So it's kind of like a denture, you can remove it. Okay, now with the MSE, everything is intact. So when you expand, you naturally have to expand your nasal volume. So our double jaw surgery always precedes with MSE to improve it. Now, one of the funny facts is a lot of patients come in diagnosed with all kinds of airway problems during CPAP machine and this and that. My recommendation is MSE and then jaw surgery, either mandibular advancement or double jaw surgery. And after the MSE achieved the result in a month or two, a lot of them actually claim that, you know what, my airways problem's gone, okay? My snoring problem is drastically improved. I don't know if I need the jaw surgery, okay? So jaw surgery become more of a aesthetic enhancement for some of them, okay? But I'm not denying the double jaw surgery usefulness, because airway is basically four big components. One is your nasal volume. Second, it's a pharyngeal space. That's where people get tonsil removed. Three is the tongue volume. Number four, it's a combination of a tongue position and jaw position. If your jaw is more forward, your tongue's more forward. Your jaw is more backward, your tongue's more backward. Mm-hmm. Patient with tongue tie and so on. Those are the tongue position. Now, when you do MSE, you correct three facts. Number one is you actually increase the nasal volume drastically. Number two, because your whole palate get widened, so as your pharyngeal space get widened. Number three is you increase your tongue space. So out of 3 out of 4, you got improvement of 3 out of 4. Then those changes might be enough to make you within the normal range of the airway, proper airway patient.
Right, okay. Right.
So the number 4 factor becomes something luxury, because people always have second thought when they're going to have surgery. Okay.
Tell us about what you mean by number 4.
Number 4 is the lower jaw position.
Right.
Okay. So improve all of that is good enough. Now, for some hardcore patient, yes, we still do need to move both upper and lower jaw forward.
And by hardcore, you mean extreme cases of really severe poor development.
Yes, extreme cases. But personally, I think MSE is one of the most important tools to try first before anything else.
Right, right. So there's a, let's say 10 patients present to you interested in double jaw surgery. Maybe with 5 or 6 or 7 of these patients, you can say, hey, look, time out. Double jaw surgery, it's a lot to get into. It's very invasive. There's a lot of potential side effects. Maybe what you should do is, instead of jumping into double jaw surgery, we try the MSE first. You see how you feel after we expand. Then if you're not happy, if you still want more airway or more change in the aesthetic, then you can do double jaw surgery.
Or you still have structure bite issue, okay, that you have to get a lower jaw advancement to correct it.
Right.
Then those
So
patients,
tell us more about that issue. What do you mean by that? What is that issue
now,
like?
if the patient is really skeletal class 2, for example, lower jaw is really, really inward, or the patient is severely class 3, that means the upper jaw is really, really pushed in, okay? Those patients, even with the correction, you still have a lot of bite issue you need to correct, okay? Then those patients are perfect for jaw surgery.
I see.
Yes,
I see.
I like jaw surgery. Most of my patients with severe skeletal discrepancy, I always prescribe jaw surgery. So they routinely go to the oral surgeon to get a pre-jaw surgery consultation and see if they're a candidate. I want them to mentally prepare. Okay.
Yeah, of course.
Because a lot of those cases still turn into jaw surgery cases. Okay.
Yeah.
It depends on how deficient, how much discrepancy you have.
So you have a jaw surgeon that you have a relationship with, that you work together with on many cases, and you guys probably talk a couple times a week and you work together closely. And is this an important thing for any orthodontist, especially an airway focused orthodontist, to have a working relationship with a surgeon that they can?
That's a must. It's a must have when you have a surgeon that you know what they're doing and they know what you're doing, and they will trust your work and you'll trust their work. And when you send them to a surgery or surgical assist, they know what they're getting into. I have experience with some other surgeon, mainly Kaiser, because Kaiser oral surgeon, they don't talk to anybody else. They have no letter communication, they have no phone call communications, and they will say things against it, the procedure. And I have a patient, we have a MSE put in, and a month later, come back on the MSE up because the jaw surgeon wanted to be out. Okay, and so you will get those kind of frustrating issue if you have a surgeon that doesn't work with you, doesn't have the same goal, the same sharing of the knowledge. Now, my oral surgeon himself, he actually putting MSEs for other orthodontists. So
What's his name? Dr. Stephen Vaughan, is that
Stephen
right?
Vaughan, Vaughan, Stephen Vaughan. He's
Got it.
practiced in Full Hill Ranch, California. It's about 10 minutes away from my office, pretty close by. And he's a surgeon I seeing, you know, we synchronize, we look at the same level. So when he called me and contact me or text me, he just mentioned something, I know what he's talking about. I mention something, he know what I'm talking about. That's an important relationship to have with the surgeon. So you don't have miscommunication or work against each other and providing patient conflicting ideas so patient get confused. Okay. That's the last thing you want to do, is have patient get confused. Now, confused from a person with experience, that's good. That's patient gain more knowledge. But many times you have doctor give you a conflicting idea where the doctor have no knowledge of that field. Then that's a problem.
Yeah.
For example, an oral surgeon coming on the MSE where he doesn't know anything about the MSE, or another orthodontist coming about MSE, we haven't done a single case or never even attended any classes on MSE. Then those are just guessing.
Yeah.
Not really a valid opinion. A valid opinion is today I'm an MSE provider, and the patient went to another MSE provider who did 50 case, 100 case. Then his opinion definitely count.
Right.
That's a valid opinion. Or you go to an oral surgeon who did plenty of MSE and work with a surgical assist MSE. Then that's a very valid opinion. Or the surgeon is very concentrated on the improving airway matters. Then that's a valid opinion. Not someone who have no experience, just talk, then those opinions really will hurt patient, not providing a help, instead more damaging to patients seeking proper help.
Yeah. Yeah. No, it's a very common thing that I see with people who talk to me, is that they talk to too many different providers in too many different schools of thought. Okay, so when they talk to one type of provider, it's this, and another type of provider, it's that. I think it's so important to find a team of airway focused dentists, doctors who understand the importance of appropriate expansion, and then who also understand the tools that are available to accomplish that, and then to just kind of invest and commit to an orthodontist and a surgeon, maybe a periodontist, maybe an ENT, who all kind of see eye to eye on the same philosophy, this airway focused philosophy.